Oh, hey, Chris.
Hey Chuck, how are you?
I am great because we are recording a pod.
Absolutely. I wish I could say I was full of energy, but it's been a rough it's been a rough day.
What, too much cooking?
No, I did do some cooking and that was fantastic, highlight of the day. But last night I wasn't on call, but we're participating in this multi-center randomized controlled trial for PEG fusion for nerve repair, and duty called. And when I got the call from one of our partners, it was early evening, and I said, "All right, great, this is perfect. We'll get the patient enrolled if they want to do it, and we'll do the case, and I'll be in bed later." And the case I was supposed to go in the evening got bumped for an emergency cranie, and then it just kept getting bumped.
All right, well, talk to me a little bit about this because I know about this study. I'm not one of the surgeons. I haven't had the opportunity to pass one of these cases off, but I look forward to that day. But tell me a little about this study, and are we? It's a multi-center study, as I understand it. How are we doing comparatively?
So, it's a PEG fusion technology. For those that are unfamiliar, it's not new. It's actually been around for quite some time. So some of the old guard will say how it's come and gone. But there are some newer studies demonstrating that PEG fusion, in which you repair a nerve as you normally would with suture, and then you use essentially a chemical to help seal the nerve ends together after you've repaired it, and supposedly helps to facilitate and expedite nerve regeneration. Really impressive in the lab and really impressive preliminary papers. But this is a technology that's now being put to the test with a multi-center randomized controlled trial. We are one of, I believe, at least 8 sites. I think they're still maybe trying to recruit more. And we are in the lead.
Nice. Well done. This is you and Dr. Brogan, I believe.
Yeah, so David's the PI on the study, and we've got a great research team who really are just handling the majority of the work. It is a ton of person hours, as we should say, that goes into not only recruiting, enrolling, doing the randomization, and then all of the paperwork that comes with the follow-ups. We're very fortunate to have Carrie Burke and Yosita Beamer, who are a fantastic clinical research team. We had a visiting a scholar for the government scholarship, Avi Galati, recently, from his center at Curtis, and he was saying how it's a hard study to enroll just because the criteria's got to be perfect. It's got to be a nerve injury that can be primarily directly repaired within 48 hours of injury. So it's very hard to thread that needle.
Yeah, for sure. I mean, fortunately, with our population, we do have more opportunities for acute repairs just because of the nature of our center, but it's still not easy. Still not easy. And you're right, you can't do these kind of studies without the right team. It's hard enough on the surgeons, but having the right team behind you is really, really important. So congrats. Keep up the good work.
Yeah, so David and I are very proud. We're well ahead of our counterparts at other institutions. And hopefully, we're helping the advance the field in that regard. So I'm tired, to be very honest with you, because that case went overnight and then it just rolled right into a normal day, which included, and we talked about this on a prior episode, because I'm traveling next week. I added on a clinic this morning, and it just kind of went from there.
Well, in respect of your time, let's do two things. One, there's a great review to share. And then two, given that you're tired, the easiest thing for you to talk about is nerve. So let's talk about a nerve we haven't talked about in a while.
Well, so here's a great review from Ani Stratman, who is a early career hand surgeon in Europe. He didn't say exactly where he is. Looks like Germany based on the email address. But he said, "Hey, Chuck and Chris, I usually listen to your incredibly interesting podcast on my way to work. One morning, not that long ago, I gave my 12-year-old daughter a ride to school, and after listening to you for a few seconds, she said, 'Wow, this guy sounds like Tony Stark, Iron Man for the Marvel Universe.' And that was you, Chuck." Her
I, do-
comment made me laugh out loud, and I hope it makes you smile at least.
I wish I could say I'm a Iron Man watcher, so it doesn't really mean anything to me, but it still sounds like a compliment, so I will take it.
That's a huge one. That's big. That's big. Tony Stark is a good one.
Thank
So,
you.
and then he goes on to very kindly say, "Your podcast is awesome. It's easy to listen to, and every time I pick up something that I haven't thought or simply never heard or read about, I'm deeply grateful that you share your knowledge so generously. You make me a better hand surgeon. And I must mention, I'd love to hear more nerve."
Well, let's give it to him.
Absolutely. And then Ani goes on to a request to be put on the newsletter email list. So we will definitely add you. And then anybody who wants to, please let us know. There's a link in the show notes. You can always email us, handpodcast@gmail.com, or find us on social, and we will be happy to hear from you guys.
I love it. And that is a very kind review, and those words really are impactful. So thank you for sharing, and we will definitely add you to the email list. All right. So I think we both delve into this lower extremity nerve at times. I have mentioned on previous podcasts that I work pretty closely with some of our sports surgeons. And so there has been an opportunity to work on this nerve. And likewise, they know you are a great resource, especially as this injury gets more serious. So take us into our topic.
Well, I mean, even though this is a hand surgery podcast, hand surgeons get called to operate, all over the body, like any of our partners who do lots of flaps can tell you. But for a nerve, you're oftentimes asked to help your, or at least orthopedic partners, with dissecting out and maybe even decompressing the common perineal nerve. So you mentioned it in the context of, a knee injury in which maybe they're going to do a reconstruction of some sort. But I oftentimes see it in the patient who has a foot drop for unknown reasons, supposedly, or they have double crush and have had some lumbar spine issues, and they're still not recovering their ankle dorsiflexion. And it's usually seen on the nerve study. So I've found this to be an incredibly useful nerve to learn about, and a great procedure to learn and to teach. And I tell every resident that comes through, it'd be great if you came off of this rotation knowing how to find this nerve, get it dissected out safely, because you never know when you're going to need to do it. And then for our fellows, it's a great procedure to know how to do, because then your partners can ask for help.
Yeah, and those collaborative cases, as you and I both strongly believe, are fun. Although I will say, a knee dislocation or a posterolateral corner injury to the knee that has been untreated for some time, that perineal nerve gets scarred in, and your fun with your partner can go south really quickly. So
Yeah. They
those are.
they um they definitely they definitely want your help. I don't know if they just wanted to say that you were there to dissect out the nerve, but those are hard. They're incredibly scarred, and I mean, think those are, multi-legs and posterolateral corners. Those are really challenging injuries just in general. During the beginning of the pandemic, did a webinar for the American Orthopedic Foot and Ankle Society, and it was me, Jeff Johnson, Matt Matava. So Jeff's a sports surgeon, or excuse me, a foot and ankle surgeon who recently retired. He's now practicing at the VA. Really well known in his field, an expert at the bridle procedure, the combination of tendon transfers to restore ankle dorsiflexion. And Matt Matava, former, sports, or former team doc for the St. Louis Rams, and an incredibly well-known sports surgeon. And then our last panelist was Susan McKinnon, who obviously needs no introduction as a peripheral nerve expert. So I'm moderating this panel, which was super fun to do, showing cases, and we agreed on nothing, which shows you just, I mean, not even like, what's the best strategy in terms of timing of each of our individual surgeries, what to tell the patient to expect, what's most important in terms of outcomes. It is wide open in terms of finding some way to unify everybody into figuring out what to do with these patients, because universally they don't do great.
So true. And that's no matter what the situation is, but especially with those sports injuries. So let's play some yes, no. Do you always get a nerve study in the setting of a traumatic perineal nerve injury?
Yeah, I do. And we can elaborate if you want me to or not, but I think it is useful. It gives us a good baseline. These are always such poor prognostically, it's pretty poor most of the time, just because of the force on that nerve that, if it's enough to disrupt, give you a multi-leg knee, disrupt the posterolateral corner, ACL, PCL, it's going to be bad. And typically that zone of injury to the nerve is incredibly broad, and that is pretty much directly associated with their ultimate outcome, because there aren't great options in terms of nerve reconstruction there, if the zone of injury is really wide. So I like to get the nerve study just to establish, honestly, how bad it is. And then if it's, you usually don't have the luxury of time in these patients, because you don't want to go after the knee surgery has been done and everything has re-scarred back in. So you kind of got one shot, and that's when you got to negotiate with your partners as to when the right timing to do it is.
Yeah. And as we all know, our sports surgeons will definitely get an MRI. Is that sufficient for visualizing the nerve, or do you need an ultrasound?
I think it depends on where you are. I think one thing that I like about the ultrasound, not only in this context, but just in general, is that For injuries in which you have a closed or a ballistic mechanism, an ultrasound can pretty quickly tell you, is this a nerve in continuity or not in continuity? And that has been really helpful for us. For example, for things like, gunshot wounds, which we see in St. Louis around the knee, getting an ultrasound has told us that nerve is not in one piece. And then why wait any longer than you have to get the patient on the schedule because you have a shot, if you get there early. So I like the ultrasound for that reason. I think the MRI is useful, but I still like getting the ultrasound because it gives me the exact information I need, and I can't always rely on the quality of the MRI.
Perfect. Unless you have other preoperative considerations, I'd like to jump to just diving into the weeds of the surgery. Um,
Well, I mean, I think what would be more useful than talking about it in the multi-lig context was just kind of a standard common perineal nerve decompression,
Perfect.
because that's what most people are going to be treating if they do treat this population. Honestly, it's not that different than many of our other upper extremity nerve decompressions. So the CPN, oftentimes you'll see patients with a foot drop, either a florid foot drop or just motor weakness in trying to bring their ankle, into dorsiflexion, and oftentimes that great toe kind of drags down. That's in addition to the classic paresthesias, like you would for any peripheral nerve, and this one happens to be on the dorsum of the foot typically. There are a couple of pearls that I like on the physical exam, and maybe you could share your, expertise in this too. But oftentimes, patients are pretty strong with ankle dorsiflexion, and you kind of have to work hard to show them, that they're particularly weak. Now, if they are, you want to make sure that you're pulling real hard on them and show them on the other side how strong they are. Oftentimes, if they're strong enough on the other side, you kind of pull them forward on the chair or kind of pull them off the exam table almost, and you can really find some weakness there. For the ones that have a florid foot drop and you're looking to see if there's any recovery, I think crossing the leg over like you're making a figure four, is very useful to take gravity out of the picture to really find that kind of M2. And that's one thing that I show our residents and fellows all the time.
No, I love those. I don't know that I have more to add. I really only do this operation in the context of a multi-ligamentous knee injury, but I now have the lingo down. Chris texted me earlier to suggest this topic and said, let's talk about CPN. And I'm like, CPM, CPM, CPN, what the heck is going on? But now I know
Uh,
if I want to be a real nerve surgeon, I have to have the lingo down. So CPN, common perineal nerve, I
there you
got it.
go. Nice, nice. And then the other pearl that I found on exam, and this is all stuff that, I mean, I didn't see this in fellowship. I just kind of learned it along the way. With checking ankle eversion, which is the function of the Perineous, Longus, and Brevis, oftentimes when you do that, patients will use a lot of compensatory muscles to show you to basically try to evert their ankle. So if you're not careful, you will see they will compensate by externally rotating their hip, by abducting their hip, and activating their IT band. So you'll see these things. So I really try to, when I'm examining them, have one hand on the outside of the knee to stop them from compensating that way, and then really see how well they can evert out. And I've found that to be helpful. Again, demonstrating to a patient that there is something, that's visible and notable on an examination, I think is compelling at a lot of times, especially if you're in the context of, maybe we should talk about surgery.
So are these patients usually sent to you for surgery? Because I assume you're not commonly making this diagnosis on your own.
Um, no, I mean, they're usually sent to me with, evaluate for foot drop, or they've come from the foot and ankle surgeon because they were sent by the spine surgeon to the foot and ankle surgeon for a tendon transfer. And they said, well, maybe there's something in between that we could do. And I think that, our residents and fellows have helped kind of drive this too, because if they're rotating with me and then they go and rotate with one of the other docs and are doing a Tenel sign around the fibular neck, super helpful for me because they'll bring that up, I think, with the faculty that they're working with. And I think a Tenel sign is really helpful in this particular condition because sometimes it's not necessarily a foot drop, it's just a paresthesias that bother them.
Right, right. Okay. Um, we've talked about exam, we've talked about imaging. Is it time to talk about my favorite thing next?
The nerve study? Yeah.
No, no, I can't take it anymore.
Well, I think for CPN, I think that, there's the lingo again. And our physiatry colleagues will call it the fibular nerve instead of the perineal nerve. So just, we may be caught off guard. I think ultrasound is super helpful in terms of looking at enlargement, especially compared to the opposite side. Analogous to cubital tunnel, it's, a nerve working its way around the bone. So looking for a conduction velocity loss is useful. And then also looking at changes in the motor amplitudes. But again, that's a topic for kind of really getting into the weeds. But I think surgery, it's a great surgery. I'll be honest with you. I think it's a fun surgery to do. I think it helps patients a lot. And I've even done it awake.
I did an awake surgery today, which I should tell you about at some point. But all right, I love it. So, is it time?
It's time. We can talk about the surgery.
All right, I want to start with your positioning. How do you position the patient on the table?
So this is a case where I don't know what it's like at other places. At least the culture here has been for these, relatively short ambulate, outpatient hand surgeries, essentially anything 2 hours or less. We do everything on the stretcher here with a hand table kind of slid underneath the stretcher. For me, this is no exception. I think that it's great to do a non-sterile tourniquet, bump under the ipsilateral hip, making sure that you're able to externally or internally rotate them a fair bit. And especially if we're going to do a superficial perineal nerve decompression at the same time, putting that little bone foam wedge, sliding it right underneath the upper thigh on the posterior aspect, I think is super useful in terms of getting them exactly where you need them to be. How do you position them, or is it mainly dictated by the sports surgery?
Yeah, I don't usually get a lot of say. I do my darndest to get a bump under the hip to give me some of that positioning, but usually I'm in an awkward, position trying to find
That
the
that
nerve.
thigh that thigh holder is the worst. That they like that little U that they put underneath the posterior thigh. That just hoses you every time.
Yeah, thankfully they're not usually scoping. So it usually is just supine, but it doesn't make it any easier because their goals and my goals are not the same, other than great care for the patient.
Right, of course. You don't quite think about that. And if you ever are going to be in a case where somebody's scoping, you need to go first. Because once those subcutaneous tissues get blown up by the liters of fluid that get pumped through there, all your normal planes are gone. You take a surgery that would take you a much shorter period of time, and you can double or triple the time needed.
Absolutely, absolutely. So usually what I have done, again, in the context of working with one of my sports partners, whether that's pediatric, sports or adult sports, is sort of just a posterior lateral incision sort of over the fibular head, heading proximally. Um, I try to always, it's classic for me, I always start small and end up enlarging my incision. Tell me about your landmarks for your initial incision.
I think that that's pretty much how it goes if you're working with somebody who needs to get to the posterolateral corner, is that they're going to want to cheat the incision probably more proximal, or I guess the technical term is cephalad, than where you would normally put it if you were just working on the nerve. If I'm just working on a nerve, it tends to follow the course of the nerve. So it tends to sit a few centimeters distal to the very proximal end of the fibular head, because that's where I know the nerve is going to be. I don't go straight transverse. I know there are a lot of different ways to make this incision. You just got to find the nerve, and you know the nerve is going to wrap just below the fibular neck. Basically around the neck at the head neck junction. And in Missouri, that's a little bit hard to feel that fibular head in some patients. A very reliable landmark is the tibial tubercle, because proximal to distal, the tubercle tends to lie at the same level as the fibular head. So when you can't feel the fibular head in some patients, just mark it off of the tubercle in terms of how far where to put your incision. So I found that very useful. It tends to be almost a transverse, but kind of more oblique. And it goes all the way from kind of close to the tibial crest, because I want to make sure I get over there, and then carrying it, just posterolateral to the fibular neck.
So, to clarify, I'm going to translate for Chris. In Missouri, some of our patients are large, and those large patients, it is so true, it can be difficult to palpate the fibular head, but that is a fantastic trick. I have heard that before. Use the tibial tubercle for your proximal distal or cephalad caudad alignment. So you go to the neck slash posterior aspect of the fibular head, find your nerve, and then
Right.
trace it proximally and distally, working through scar tissue if it's a post-traumatic situation. If it's not post-traumatic, I don't think there's any magic or difficulty in finding it. But in the post-traumatics, if you
Oh yeah.
haven't done this before, it can be a bear.
Yeah, absolutely. I mean, I think in the post-traumatics, you tend to be going proximally anyway. The short head of the biceps, if it's intact, is your home, because you know that it's going to be tucked right behind. So if you feel on yourself, if you're listening and you're not driving and you can feel your short head of your biceps on the posterolateral aspect of your thigh just above your popliteal fossa, you can feel that tendon. You can roll it around. That nerve is going to be sitting tucked right underneath there. And if you're slender, you can actually feel your own perineal nerve. And oftentimes patients can sometimes get some compression there if they cross their legs, in a certain way. But so I use that as home when I'm doing the more proximal dissections because it tends to be more normal up there. Although sometimes with these wide zones of injury, it can be pretty rough. In terms of that initial approach in the non-traumatic setting, if it's a trainee that's starting off the case, just in terms of getting them oriented and setting their depth, I'll have them dissect and start with the knife, and then really get to the fascia on top of the anterior and lateral compartments. Because once you're going from anterior to posterior, you kind of fall off a cliff. And if you're obviously too deep with your scalpel, with whatever instrument you're using, you're going to get close to where the nerve is really coming from the back and coming to the front. So setting depth on the fascia, and then after we've set our depth, then going back and finding the nerve as it wraps around the fibular neck. I like to see the nerve all the way posterior, and then after that, then come from posterior to anterior.
And how far proximally in a non-traumatic situation do you tend to decompress it or
I don't
trace
I
it?
don't think you need to go very far. Honestly, once you've seen it kind of wrapping around and coming from posterior to anterior, you inspect and you make sure there aren't any odd bands that are back there. I know that some are more enthusiastic about releasing all that fascia. I don't think it's particularly helpful because once I've found that, then I go from P to A, from posterior to anterior, and I find that first point of compression, which is usually the worst one, that the posterior crural septum, which is that kind of back edge of the Perineous longus, and just start releasing there because that usually is the most offensive point of compression.
Okay. And how far distally do you trace the nerve into the muscle?
So then, what I like to do with this decompression is that, you see the fascia of this is pretty interesting. It really does wrap around the individual compartments and then in the anterior compartment between the muscles. And it's almost like the fascia is coming up and you've got the muscle on each side of it. It's almost like an I-beam. So, finding the back edge and releasing that posterior lateral portion of the deep part of the lateral compartment fascia is the first step. And then after that, it's really retracting and being kind to that lateral compartment musculature as you're releasing it. Because unlike, for example, like a flexor pronator release, if you're doing an ulnar nerve submuscular transposition, some of that nerve supply to the lateral compartment comes in proximal to where the fibular neck is crossing. So if you just were to take a bipolar or a bovie and just go right through the muscle to release the nerve, you'd actually be losing some of the nerve supply that you're trying to keep to the lateral compartment. So you really have to dance around the muscle and release the deep fascia, get over the top, and then get some kind of, like Dr. McKinnon calls it, down curve retractor. Other people call it like a laying back, or you can even use the Ragnell. Get on the other side of the lateral compartment, release that anterior crural septum, and then work underneath. And that helps you set your depth. And then it's just individually hopping over each of those little fascial vertical bands and releasing them. You go posterior septum, your anterior septum, and then the so-called innominate septum. It's usually not the innominate septum that's tight, but it's usually posterior than anterior that are the tightest.
Two more questions. One, nerve stimulator, and in which situation would you use it?
I think the nerve stim is useful, I guess, if you're having a really hard time finding the nerve. Usually, if you're having a hard time finding it, it's in a post-traumatic setting and you've already been digging through scar and the tourniquet's probably been up a while. I don't think I don't use it routinely in a non-traumatic setting or even in a traumatic setting. I think there's probably is a role for nerve-to-nerve action potential, like kind of two probes, one on each side of a scar, and seeing if something conducts across it if you're looking at a dense neuroma and continuity. But I have not used a nerve stimulator in this setting unless you kind of come across a funny branch and you want to see what it does. How about you?
Yeah, I haven't used it. I've often wondered, in that situation with a post-traumatic, would it be helpful? I haven't ever thought it would be helpful in finding the nerve, and so I haven't done it. So I'm actually happy to hear that you haven't. And then the second question is, if one of our listeners who may have done this but not done it recently wants to review some of the anatomy that you have alluded to, is there a best source? And we can always put it in the show notes if you don't recall it off the top of your head.
So Dr. McKinnon has great videos on this. I don't do it exactly the same way, but whenever a trainee comes to the service, current generation of trainees tends to go to videos by and large. So I send them to her videos. I think they're great. I think they're on YouTube as well as her education platform. One of our residents who is matched at Harborview for his hand fellowship next year, Nish Dvivetti, he and I wrote some review articles on this, which are in the orthopedic clinics in North America at some point in the last year or so. And then Paul Inklin, who is going into sports at HSS next year, he and I wrote an article that summarized the webinar that I mentioned earlier. So there's a bunch of stuff out there. Those are good ones. They actually kind of include a lot of the anatomy resources. And there's a lot to unpack here in terms of all the variations in the anatomy, and we don't need to get into all that detail. One thing that I think is important is that I was teaching one of our fellows recently was that once you've released your CPN, I like to see the branching of the deep and the superficial perineal. And sometimes even it's not so much a bifurcation, it's even a trifurcation. You can even see some branches, not necessarily to the joint, which is what's in the book, the articular branches, but there are some branches that go to the tibialis anterior that come off more proximal than you think. So you really got to be careful about saving whatever branches come off because they may be going into the muscle, and you can trace that if you'd like. But then I think also releasing proximal to distal, releasing some of that posterior crural septum along the course of the superficial perineal nerve can help because even though you've released the deep component, if you don't release that back part, it can hang up the superficial perineal nerve too.
I love that. We
Sorry,
have
this got really jargony and really nerdy really quickly.
No, I love it, but I'm going to take it to the basics. Here's my two. You got to come up with two, but I, of course, have two. Here's my two take homes. Number one, you got to know the anatomy. And in this situation, if you're not there all the time, you got to know it well. And so prepare for cases like this. Number two, if you heard Chris say this was not something he got a great deal of experience with during his training. So your learning and your potential for cases and even specialty focus absolutely should and can extend after your training is over. So it certainly has happened to me. Elbow arthroscopy is the example, and just a lot of work around the elbow is an example. So I love that, and I think it's a good message for all of us.
Yeah, I mean, I think that obviously I'm biased because I'm the fellowship director now, but I think that we offer a great fellowship because we give you tools for your toolbox, so that when you leave here, you can learn and teach yourself to do these kinds of surgeries, obviously with the appropriate preparation, both reading videos and then even getting into the cadaver lab. But I remember, doing this procedure as an attending for the first time and going to the lab and practicing, and taking pictures and all that kind of stuff, because it's technically a pretty straightforward procedure. Like you said, you got to know your anatomy, but and it's a great service you can provide for your patients and your partners.
I love that. I think we should wrap this up, and you should go to bed.
Yeah, no, I'd like to, but there is some more stuff to be done tonight beforehand. But I thank you. I appreciate that.
All right. Have a good night.
Good night.